All right. Good afternoon. I am recording this now again after I have just presented to the group in person and online, as I forgot to hit record. So bear with me and we will get through this. It's about 15-20 minutes. But yes, so today we're talking about Mast Cell Activation Syndrome, or MCAS, which is the third diagnosis in the common hypermobility trifecta. So that includes hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome, which we covered in the first session, POTS, which we covered last time, and MCAS. So those three are very commonly seen all together, and we'll talk about what MCAS is today. So just a reminder, I'm Steph. So I'm an osteopath working here at North Canberra Osteopathy, and I exclusively work with hypermobile adults and teens, and I work with all kids and babies. I'm a lived experience practitioner, so I have the trifecta of MCAS, POTS, and HEDS, which I have now been diagnosed. Very excitingly, you may notice that different from the last video. I've also been diagnosed with endometriosis, adenomyosis, and PCOS. It's been a crazy couple of months, but I've reached the safety net, so we're getting all of the diagnoses sorted while I can. And I have said it before, I also have autism and ADHD, which are basically the whole collection of comorbidities. Touch wood, I don't need any more. I'm getting a lot of the bingo card. So I am extremely passionate about all things hypermobility, which is why I created this program, this group, to teach especially the people here in Canberra, but I'm posting these online so that I am teaching everyone that wants to know about hypermobility and the comorbidities and making it accessible to the public so that anyone who wants to know this information can. And specifically talking about it in an Australian context, which isn't always easily available. So I am an avid romanticy reader. I love reading so much. I'm going to go home and read now after this. And I am an anime enthusiast. I love my anime. So I am also dog mum to Angus, who is, you can see here in this picture. He's also running around in the clinic here somewhere, but he's mad at me because I won't get his toy. So, and cat mum to Piper, who is not pictured here because she doesn't love being that close to the dog. So, what is MCAS? So, Mast Cell Activation Syndrome can be defined as a large and varied group of disorders presenting with episodic symptoms involving multiple systems that are attributed to mast cell activation and its subsequent mediator release. So, mast cells are a part of our immune system that live within the connective tissues, which is why it makes sense that this is more common in people with hypermobility as their connective tissues are structured differently. They are involved in allergy response and also tissue inflammation and repair, vascular homeostasis, and defense against various pathogens. So, those are the normal roles that they play within the body. They contain various inflammatory mediators which are released upon activation. So mast cells can be activated by both IgE, which includes anaphylaxis, and non-IgE mediated allergies, including things like celiac disease. So basically, any form of allergy is going to be activating some mast cells. But otherwise, we can have pathological activation of the mast cells, which is can include increased numbers or function in the absence of normal allergic triggers. And we've also got activation and release out of proportion to the stimulus, so an over reactivity. So mast cell activation, which is what most of us will have some level of, whether we qualify for the syndrome or not, is defined as the release of mediators and mast cells due to activation. This can be local, with a runny nose or asthma just in the local tissues, or it can be systemic, so whole body, which includes anaphylaxis, and those can be with varying severity. So tryptase is one of the mediators that is released by mast cells, and activation is marked by an increased serum tryptase level during an activation event or within 4 hours, as we'll talk about with the diagnostic criteria. So there's MCAD and there's MCAS. So MCAD refers to mast cell activation disorders, which is an umbrella term which encompasses a group of disorders in which mast cell activation occurs, including MCAS. And so MCAS is mast cell activation syndrome, which is a syndrome that is specifically defined by certain criteria, where there is a history of systemic and recurrent mast cell activation with evidence of mediator release, such as tryptase, and response to medications directed at mediators and their effects. So you respond to the medication. So, classification of mast cell activation disorders, we've got primary, so a group of disorders that are due to a defective mast cell precursor. So, the cells that mature into mast cells are defective, resulting in an increased number or increased function of the mast cells. Then we've got secondary, where we have the normal precursor cells and normally a standard amount of the mast cell numbers. However, they are activated by microenvironmental triggers, and in other words, the population of mast cells is hyper-responsive. And then we have idiopathic, which is where that happens with no identifiable cause. So this is where mast cell activation syndrome falls because we don't know what's causing it. Mast cell activation criteria, MCAS criteria, so the syndrome criteria, are recurrent severe symptoms of mast cell activation. So they must be severe and they must be happening somewhat frequently. Objective evidence of mediator release, so an elevated tryptase serum level in a blood test within 4 hours of an event, so within 4 hours of a flare. We've also got elevated 24-hour urinary histamine metabolites. So elevated urinary prostaglandins, because that is a metabolite. So what the histamines are broken down to when they are excreted as urine. So within 24 hours of a flare. And then we've also got response to therapy. So anything that blocks mast cell mediator activity. So we've got H1 blockers and H2 blockers. So H1 blockers are the antihistamines that you can get over the counter, such as Telfast, Zyrtec, Claritine, those sorts of things. And we've got H2 blockers, which are commonly reflux medications that the GP has to prescribe. And then there's a couple of other specific medications. I will link the resource that I used to create this for anyone that's specifically wanting to know about those medications, as it's something I was asked after the presentation, that some of the different medications are all listed there. So what are the symptoms? So I just mentioned you have to have severe and recurrent symptoms. There are a lot. So basically we're going to go through what the mast cell activation syndrome questionnaire has, and it's got symptoms that occur basically in every system. Because it is important to point out that those symptoms are not specific to MCAS. So MCAS symptoms are never only going to be, if someone gets them, it's not always going to be MCAS. Like you can have hay fever just normally and things like that, but mast cell activation syndrome will have a more severe response most likely. So that's to say that this is a diagnosis of exclusion. We have to rule out that any other disorder or syndrome or diagnosis isn't responsible for the symptoms. But once we have done that, the symptoms of mast cell activation are inflammation that can occur in any system. So when we think about the fact that the mast cells release inflammatory mediators, they are designed to promote inflammation, as that's how the body knows that there's a problem and can come and heal it. But obviously it then causes pain and things like that. So that can then lead to all of these symptoms. So we've got the constitutional symptoms, so significant physical weakness or fatigue doing everyday tasks. We've got every extreme fatigue attacks, so it is hard to keep your eyes open, and unexplained weight loss when you've had no change in your regular diet are all potentially linked. We've got ears, eyes, nose, mouth. So ears can be ringing or have odd sounds. We got eyes can be dry, itchy, red, burning, or feel gritty. We've got runny or stuffy nose, and we've got inflammation and ulcers of the mouth. And it's important to point out, like ulcers for the mouth, you can have very commonly with hypermobility because of the connective tissue of the mouth being more fragile. We end up like you accidentally bite your cheek and you get a massive ulcer. That sort of thing is very common with hypermobility. We got chest and heart symptoms, so burning and or pressure type pain in the chest when tests were normal. So that's the cardio stress test and an ECG. None of those showed anything. We've got rapid heart rate, so palpitations, which, as we know from the last session, is associated with POTS as well. So there's crossover there. We've got redness and flushing of the skin, especially the face and upper body. We've got hot flashes, which are not menopause, but they are usually last 2 to 5 minutes, but are in that 10-minute limit, often accompanied by nausea or other symptoms, but nausea is the most common one. We get sudden dizziness and lightheadedness with fainting or near fainting, which also again is a symptom of POTS. So we always keep that in mind too. And a sudden temporary increase in blood pressure. So basically, if it comes up really quickly, but then kind of goes back down. The lungs, we've got an irritable, dry, or cough, or a need to cough quite frequently. Feelings of shortness of breath or difficulty taking a full breath, which again, I know a lot of us have issues with ribs and rib pain, and so that can be a cause of that as well. And asthma-like complaints, so wheezing. We've got the abdomen, so we get nausea with or without vomiting. Abdominal pain, especially if the pain is a burning pain, cramping, or spasming pain. And then again, if it's in plus diarrhea is very common as well. But it doesn't have to be. You can just have the pain otherwise. Marked attacks of visible bloating or distension within 10 minutes of coming into contact with something that you react to, commonly eating with these ones. A surgeon has performed an abdominal or pelvic surgery or laparoscopy for the very first time and found adhesions or scar tissue in the abdomen. So it's specific to the first one because after you've had a surgery, those can cause the scar tissue and adhesions. But if that is occurring without that precursor surgery, then we can be looking at MCAS sort of things as well. For urine and pelvis, we can get bladder and or pelvic pain, and this is for all genders, and it is often associated with painful, frequent, and or urgent urination, and may also be associated with pain during sex. And also just a reminder, so that urination stuff can all be associated with prolapse stuff as well, which is common in EDS and hypermobility, and may be associated with pain during sex. That is also a common symptom of endometriosis as well. So during these times, bacterial cultures and urine analysis are normal, or the questionnaire asks if you didn't go to a doctor to have it tested, because often a lot of us are dealing with these things quite frequently. We don't go to the doctor every time. Headaches, so neurological symptoms, sorry. May or may not be maybe throbbing on one side only and often have been previously diagnosed as a migraine. We get brain fog, so problem finding your words when you're speaking or trying to write something, or and or concentration difficulties, which again is also associated with ADHD, and with or without associated insomnia episodes. So that is also linked with hormonal stuff and ADHD as well. We've got neuropathy, so leg pain or arm pain, and or feelings of numbness, tingling, pins and needles. And this does not respond to over-the-counter pain medicine. That pain is also often described as burning, like really shooting, lancinating pain or electric pain, where it's kind of like shocking, zapping kind of feeling. That's how most people have described nerve pain. So that's a distinct classification there. We've got skin. So skin, we've got hives, so raised red itchy spots, itching with or without skin changes, itchy skin lesions that look like acne in the corners of the mouth and lip area, nasal lip area, the chin and the forehead during attacks, itching in the area around the anus during attacks, and painless, non-itchy swelling, especially lips, cheeks, and eyelids. We've got reddish brown spots or knots under the skin, and hemangiomas, which are blood sponges, which is pictured here. They're just basically benign blood vessel tumors and are very common in infants, but I just wanted to show what they look like there. For the blood, we've got bruising after minor injuries, as we know that is also associated with hypermobility anyway. We've got unusual nosebleeds and AFAB people having significantly increased menstrual bleeding, which is also then associated with adenomyosis and endometriosis. So we all need to take these individual symptoms, and if it's not explained exclusively by those things, but also having all of them together, it could still be MCAS. But basically, if those symptoms are explained by another diagnosis that you've already got, we need to have that elevated tryptase level to confirm. So bone pain that usually occurs in one or more bone. So that is bone pain is a really deep sort of ache that can be quite diffuse, quite a broad area. It's really hard to pinpoint what hurts and often very rarely responds to any sort of like you can't really get it with heat or ice or anything like that. It's quite a really deep ache kind of pain. If anyone's had any bone bruising, they'll know what that feels like. And it's very hard to describe to doctors and things like that. Um, Bone density tests often can show osteoporosis or osteopenia, especially in younger people before menopause, um, especially in young females with AFAB people before menopause. But in anyone, but the younger you are, the less likely you are to supposedly have osteoporosis or osteopenia. So that's a flag for MCAS if that is the case. Or we can see whole body nuclear bone scans that have shown increased metabolism in some areas without a known cause. So that basically means that the bone is building up in some areas without any explanation. Generally, we've got frequent colds, which turn into bacterial infections such as bronchitis or sinus infections, episodic illness that comes with attacks, and symptom-free periods that become shorter as the disease progresses. Um, Relief of nausea or other symptoms by taking any histamines and any other mast cell mediator medication. Thank you, brain. So if you get relief from those things, it's not commonly known, but if you are someone that experiences a lot of nausea, that is honestly one of the biggest MCAS symptoms, or any of these other things, you can see if any histamines make a difference. And then when you talk to your doctor, tell them that because that does put another big check against the MCAS diagnosis. So symptoms definitely link with a memorable event such as an infection, stress, or environmental change. And parents, siblings, or children have similar presentations. So there's a genetic link there. It's also common for MCAS symptoms. So I move this to the end because it's at the start of the questionnaire, but I really wanted you to find all of the symptoms. And then if they are made worse by sleep deprivation, so not sleeping for more than 24 hours, hunger or fasting, so not having food all day, which a lot of us accidentally don't eat all day with ADHD and things like that. Alcohol consumption is very commonly a big MCAS flare kind of thing. Physical exertion, which obviously there's also crossover with chronic fatigue syndrome as well. Heat, cold, stress, and high histamine foods. So that includes red wine, chocolate, cheese, tuna, cured meats, leftover meat, fermented vegetables such as sauerkraut and things like that, and vegetables such as tomatoes, eggplant, and spinach are three of the most common ones. All right, and there's the information that I got pulled all of this from. That's the references that I used. I will post those up with this video for anyone who wants to go and learn a bit more in depth about it. I basically simplified all of the information, but as I said, like I didn't put all of the medications on there and things like that. And if this is ringing any bells for you, I would very much insist that you go and do the mast cell mediator release syndrome questionnaire and then take that to your doctor to go and talk to them. So I will link that up with this as well. Thanks for watching, guys. It's been lovely. I will post this up this afternoon. And thanks for watching. If you have any questions or anything, leave me a comment, send me a message, anything like that. I'm always happy to answer questions, keeping in mind MCAS is a very complex presentation, and I will probably tell you to talk to a GP, but you're more than welcome to ask questions. All right. See ya.